Bismillahirrahmanirrahim. This is Dr. Kufran Barber from Kids Health Corner. Today is the second video of growth disorders or short stature in kids. Remember last video we said that the kids' intrauterine factors affect on their growth, and one of the most important factors is maternal nutrition. So maternal nutrition is very vital for the adequate size of the baby. If the mom doesn't get enough calories, doesn't gain about 20 pounds during pregnancy, the baby is small. Other factors like maternal hypertension, diabetes, uncontrolled, torch infections, placental causes, smoking, cocaine use can also affect the placental circulation. And the babies who are born small are called small for gestational age. And small for gestational age babies, 90% of them, they catch up on the lost height after age 2 to 3 years. 10% of them who stay small may continue to stay small compared to their families. And there is this asymmetrical SGA or small for gestational age which happens in them, and there may be a probable selective growth hormone resistance which goes away after birth, but in some people it stays, and those are the people who may continue to stay small. Other malnourished kids who are low in calories, kwashiorkor or marasmus, the protein calorie malnutrition, or later on kids who are on ADHD medications, who don't eat well, or their appetite is suppressed by those medications, they do not grow well. So I always say, just like you have to water the plant to grow, so same as with humans, they have to eat well to grow well. And a classical growth chart of malnutrition would be like this, in which you can see that this is the weight. Once the weight goes down, the height also kind of plateaus. So you have to gain weight to grow well. So this is the classic, and those kids who are born small or are small for gestational age, they are eligible for growth hormone therapy. Other cases which could be late bloomers, that parents went into puberty late. They are sometimes thought that they're very small, just like they may be in 10th grade and they may be the smallest kid in the class, and the parents are really worried, but they don't have any secondary sex characters as seen by testicular volume in boys and the breast development in girls. So the early normal for puberty, that is for pubic hair, is age 8 years, both boys and girls. Early normal for breast development or testicular development is 9 years for boys and girls. And menarche or start of menses is about 13 years for girls. And boys usually start developing their testes, start becoming bigger at 9, and later on by age 14, they should be able to go through the growth spurt. And one of the indicators of growth spurt is that testicular volume is about 15 ml, and there is a change in voice because of the thickening of vocal cords under the influence of testosterone. And both estrogen and testosterone at the time of puberty prime the pituitary gland to make larger quantities of growth hormone, which help us to grow quickly. So during the pre-pubertal growth, the growth velocity is about 2 inches per year. During the growth spurt in puberty, the kids can grow at a rate of 4 to 5 inches per year for 2 to 3 years, depending upon the family genes. So those kids who are late bloomers, they may start growing late, and they may end up close to mid-parental height. And remember, the mid-parental height is calculated by adding 5 inches to mom's height plus dad's height divided by 2 for boys. So mom is 5'5", add 5 inches, she becomes 5'10", dad is 5'10", divided by 2 is 5'10". For girls, on an average, they may be 2 inches shorter than men, so we subtract 2 inches from 5 inches from dad's height. So he's 5'10", he becomes 5'5", mom is 5'5", For example, we both of them 5'5", we add them together, divide by 2, and the mean height will be 5 feet and 5 inches. The girls are supposedly shorter than men because they have higher estrogen content, and the estrogen, which is the female hormone, it closes the growth plates. So those kids who are late bloomers, they will go through puberty late, and you will see this kind of growth chart in them, that they are growing in the lower centiles, and just before the takeoff they slightly slow down, which is called prepubertal growth dip between ages 13 to 14. And at that age we get a lot of referrals for short stature, but as soon as their testicular volume goes to 15 ml, more testosterone comes in, primes the brain, more growth hormone, and they go through the growth spurt. So this is the classical growth chart of someone who is a late bloomer or constitutional delay of growth and puberty. The growth hormone deficiency, on the other hand, which could be either because of the hypothalamic issues, by the pituitary gland disorders, which may be small or absent, depending upon the severity, the presentation could be as early as neonatal life with hypoglycemic seizures, because remember, the growth hormone is a stress hormone. It helps in gluconeogenesis, making the glucose. So those babies with absent pituitary, small pituitary, will have micropenis, small penises, and they will have may have hypoglycemia, suboptimal growth, and septo-optic dysplasia, in which kids can have optic nerve atrophy, nystagmus, absent septum pellucidum, agenesis of corpus callosum, absent hypothalamic pituitary system, small pituitary gland, ectopic pituitary, posterior pituitary, or bright spot on the MRI scan are the ones which have growth hormone deficiency, and they may have multiple pituitary hormone disorders. One of my patients who presented with hypoglycemia had growth hormone deficiency. Later on we found that he's also having central adrenal insufficiency, was also peeing a lot, so had diabetes insipidus, was missing the water hormone, as well as the child also had central hypothyroidism, and they may have central hypogonadism due to low LH and FSH when they go through the puberty. So that is the classic case of growth hormone deficiency in a neonate. In older, as the child grows older, the child does not grow well, say at age 4 years. The pituitary gland was small but was keeping up with the demand, and ultimately it fails. Or God forbid, there is head trauma which causes laceration of hypothalamic pituitary stalk, or there is infection like encephalitis, meningitis, which can involve the brain structures. Sometimes there could be tumors, just like craniopharyngioma, that can compress the stalk, and the pituitary gland may have compression of the optic chiasm. They will have visual field defects. So they could have all these lesions which can lead to growth hormone deficiency. So typically the growth hormone deficiency, they are growing well, and then suddenly they start to plateau in their growth, and if you stimulate them, do the growth hormone stimulation test, they are found to be deficient. Remember, growth hormone is released episodically during the night, and during the daytime the growth hormone level is low. So in the past, the endocrinologists used to admit patients and check their serial growth hormone levels every 30 minutes overnight, and then they developed tests. The first gold standard was insulin tolerance test. Insulin was given, which induced hypoglycemia. Hypoglycemia is a stimulant to cause gluconeogenesis, and growth hormone is released, and then the growth hormone was measured and it was found to be low. But because of the risk of seizures, hypoglycemia induced by insulin is no longer used in most centers. Arginine and clonidine, or clonidine and arginine, are used, which can stimulate the hypothalamic neurons to release growth hormone. Releasing hormone are used. Glucagon challenge is also used to test for growth hormone deficiency. So in these kids who are failing growth, if their peak growth hormone level is 10 or above is normal. If it is less than 10, we do a brain MRI to make sure that their pituitary gland is normal. And if it is normal and insurance companies approve growth hormone, we start growth hormone. And remember, the baseline labs that I had listed before in my previous video include a CBC looking for the hemoglobin, chronic illnesses, leukemias, ESR looking for any acute or chronic illnesses like rheumatoid arthritis that can cause SLE. Any chronic inflammatory disease can cause impairment of growth, because hypothesis is that they can release tumor necrosis factors, interleukins, which can suppress growth, because remember, growth is not a priority for the body. Maintaining vital structures, brain, heart, kidneys is more important. And during these severe illnesses, nutrition may go to those inflamed organs. And the bone age in these people is delayed, that is, the growth plates don't mature quickly, so that later on there is time for growth when the nutrition improves. So growth hormone, provocation test, CBC, CRP, we check IGF-1, which is a marker of growth hormone, rule out malnutrition due to celiac disease. We check thyroid hormone levels, making sure the thyroid is normal. And during the provocative test or the stimulation test to rule out growth hormone deficiency, we check the cortisol as well, making sure the child is not centrally adrenally insufficient, because if someone has adrenal insufficiency, you replace growth hormone or thyroid hormone, they can go into crisis. We also check a PMP, making sure sodium and potassium is good, the child doesn't have DI, calcium levels are normal, kidney function is good, glucose levels are normal. So all these tests are performed. And if the child is growth hormone deficient, brain MRI does not indicate a tumor, we apply for growth hormone, and the growth hormone companies approve it in underdeveloped countries, India, Pakistan. It is really struggle to pay for growth hormone. So all those people who are really, really rich, or someone can sponsor their growth hormone therapy, then they'll be able to get growth hormone. Otherwise, it's really very expensive treatment. Lastly, there is another condition which is called idiopathic short stature, in which the parents are not short, but the kid is short for no reason. On a provocative test, growth hormone deficiency is ruled out. There are no other causes. The child is really small, and this is maybe that we don't know the reason why this kid is short, and they are eligible for growth hormone therapy based on current FDA indications. And once they get growth hormone, they can grow several inches in height. So those are the other kids which can get growth hormone. And remember, growth hormone is a metabolic hormone. A growth hormone name is a misnomer. It is useful for bone mineralization, muscle development. It retains nitrogen. That's why athletes abuse it. It helps in glucose metabolism, fat metabolism, and otherwise general well-beingness. So it affects all over the body, and the growth is symmetrical. All the organs will be growing until the growth plates fuse, and if they fuse, the child is 16 to 18 years of age, is not growing well, then it can cause asymmetrical growth, more of hands, feet, and head, just like acromegaly. As far as the side effects of growth hormone therapy go, it's a safe medicine. It sometimes causes headaches. If they are severe, they can develop benign intracranial hypertension or pseudotumor cerebri. In those cases, what we do is that we monitor their vision. If it is going down, growth hormone therapy stops. Sometimes prophylactic lumbar puncture may be needed to decrease the intracranial pressure, but usually mild headaches or no headaches would be present. Kids who are very obese in puberty can have high glucose levels because it can cause some insulin resistance, because it causes gluconeogenesis, more glucose. And kids who are already obese, already metabolic syndrome, pre-diabetics can have high glucose levels. Kids who have a curved spine or scoliosis can have worsening of scoliosis. But if there's mild scoliosis, they still prescribe then growth hormone. If it worsens, they may need corrective surgery. Kids who can have scaphy or slipped capital femoral epiphysis as a site of growth hormone therapy. So if any obese child who has hip pain, you make sure that you check their hips, do a hip x-ray and ultrasound, making sure there is no scaphy or slipped capital femoral epiphysis. Otherwise, it does not cause cancer. It does not cause recurrence of cancer in those people who are cancer survivors. So it can be used about 1 to 2 years after cancer treatment in people who had cancer treatment with radiation and chemotherapy. It can also be given to some other growth hormone, other conditions which may have partial resistance or selective resistance to growth hormone, like Turner syndrome, which is XO females. It can be given in Noonan syndrome. It can be given in Prader-Willi syndrome. Sometimes HIV wasting or other wasting conditions can get growth hormone, but it is an expensive treatment. But if you can afford, your child needs it, it is really useful medications. It does miracles in the life of people who you are really trending to be very short, and when they receive growth hormone, they really feel well, their metabolic profile is improved, and their growth improves, which really helps them and improves their physical well-beingness. People who are between 7 to 10 on provocative tests are mildly deficient, 5 to 7 are moderate, under 5 are kind of severely deficient. So once they are done with the growth hormone, with their linear height, they stop growing, we stop the growth hormone, and we retest them in about 3 months to see if they need replacement growth hormone as an adult. At that time, the cutoff is not 10, it is 3. If they make enough hormone, which is more than 3, then a level of more than 3, then that is sufficient. They don't need growth hormone as an adult. But if it is under 3, they may need tiny amount of growth hormone, which could be just 1 milligram a day, 6 days a week, for the rest of their lives, to help with their muscle strength, bone mineralization, glucose, protein, and fat metabolism. So I hope that this video has increased your knowledge regarding malnutrition and growth, making sure your kids eat well. Kid generally needs 1,000 calories at 1 year of life. A rough formula is 100 calories for every year after that, until they are about 15 or 16, when they're done with their growth. Up to 25 to 2,600 calories, or if they have faster metabolism, they're really active in sports, they may get more, but at least they should be getting 1 year, which is 1,000 plus 100 calorie for every year. So if someone who is 5 years old should be getting about 14 to 1,500 calories, someone who is 10 years should be getting about 1,900 calories to 2,000 calories a day, and someone who is 15 should be getting 24 to 2,500 calories. And again, depending upon their metabolism, their exertion, their physical activity, depending upon their athlete, they may need more calories. Or if they're suffering from a serious illness, their caloric intake would be increased. So growth depends on nutrition, and those people who are severely growth compromised should have growth hormone deficiency ruled out, so that they can get growth hormone and their growth gets better. Please like this video if you have understood or learned anything from it. Share it with your friends and family and your WhatsApp groups, and subscribe to my channel, Kids Health Corner. I will continue to work on getting more informative videos for you, and best of luck to you and your families. Allah Hafiz, Sallallahu Alaihi wa Alihi wa Sahbihi wa Sallam. Assalamu Alaikum. Allah Hafiz.